Welcome everyone. Thank you for joining us for today's webinar, 2019 Updates on Guidelines in the Management of Type 2 Diabetes, Navigating CVOTs and Implications for Treatment. My name is Megan Shelley and I'll be your host today. This webinar is the first in the 2019 series of educational webinars presented by AADE in association with AstraZeneca-US Medical Affairs, Cardiovascular and Metabolic Diseases Division. This webinar is educational in nature and contains no promotional or product information. There's no continuing education credit for the webinar and handouts are not being distributed. If you would like to ask a question during the presentation, please type it into the Q&A box on your screen at any time, and we'll answer as many questions as possible during the Q&A session at the end. So I'd like to introduce Dr. Curtis Triplett, who will be our moderator today and helping with the presentation and questions at the end. He's a certified diabetes educator and associate professor at the University of Texas Health Science Center at San Antonio. So now I'll turn it over to Curtis to get us started.
Well, thank you so much, Megan. It's certainly a pleasure to be here. I just want to welcome everyone for spending your time with us today. I think we have a very interesting and up-to-date webinar for you on cardiovascular outcome trials and type 2 diabetes, and we're going to be reviewing some national guidelines for you today. We will review updates on key position statements, really aiming to provide educators with relevant historical background to new principles in the medical management of patients with type 2 diabetes. And we'll also review current recommendations focusing on cardiovascular risk, glycemic control, weight management, and the risk of hypoglycemia. We are certainly honored today to have as our presenter Dr. Susan Thomas, who is the Senior Medical Director of Cardiovascular and Metabolic Diseases at AstraZeneca. Now it's my pleasure to turn it over to Dr. Thomas to begin.
Thank you, Curtis. Good afternoon, good morning, everyone. Go to the next slide. Next one. Okay, Curtis covered these objectives broadly, so I'll get right into it. And I'll just take you through an overview of what I'd like to talk about today. First, we'll start with a background on how the cardiovascular outcome trials came into being in the diabetes space. Next, we'll discuss key findings from landmark trials and how these findings were really integrated into different types of guidelines, the ADA standards of care, the ACC guidelines, and the ACE-ACE algorithm for glycemic management. So first, let's look back at how CV safety came to be really a prerequisite for how diabetes medications should be made available to patients. As you know, FDA uses the effects of A1C as their primary basis for approval of diabetes medication. Because of the reduction in blood glucose and the lowering of A1C, showing a reduction in the risk of more chronic complications, mostly microvascular, FDA began to use this surrogate as the marker for approval. And we see this dating back all the way to the DCCT, or the Diabetes Control and Complications Trial. However, previous trials, including these, may not have included really high-risk CV patients and may have been too short to see an impact of an intervention on cardiovascular safety and efficacy. And so from a patient and regulatory perspective, they needed to see something more. Moreover, concerns started to be raised at some diabetes medications, if you'll remember, with rosiglitazone and an increased risk for congestive heart failure. In other landmark trials, ACCORD advanced VADT that looked at intensive glycemic management and early cardiovascular death. All of these put together raise these concerns that diabetes medications may actually be increasing cardiovascular risk in a patient population that was already vulnerable to the developing disease. And so, for these reasons, the FDA organized a public advisory committee in July of 2008 and subsequently published a guidance later that year recommending the cardiovascular assessment of all drugs and biologics being developed for the treatment of type 2 diabetes. So what would a cardiovascular assessment of a type 2 diabetes medicine look like? Well, these are the principles. FDA provided principles, or the guidance, as they called it, for how these CVOTs should be designed. First, I want to remind you, with a cardiovascular outcome trial, the primary objective is to assess cardiovascular safety, not glycemic efficacy, as we're used to seeing with glycemic drug trials. So the notion of a cardiovascular benefit really didn't exist at that time, since they were simply trying to rule out cardiovascular risk. Practically speaking, when you design these trials, and the manufacturers had to do this, we should look to control glycemic control, glycemic levels, and non-inferiority trials with higher risk patients would accrue more events quickly. So the objective, as I said, was to show CV safety, or non-inferiority to placebo. What does that mean when you want to accrue more cardiovascular events? Well, if you think about your type 2 diabetes patients, and you have a wide spectrum of them, if you think about a 70-year-old type 2 patient who may have actually had an event, like an MI or a stroke, and compare that patient to a 45-year-old patient who may be obese or have other risk factors like smoking or hypercholesterolemia. Your older patient who's actually had an event is at more risk to experience another event in a shorter time frame. That is called enriching a population. And so this is how the cardiovascular outcome trials have been designed in trials outside of diabetes, with blood pressure medications, statins, antiplatelets, etc. You look to reduce the probability of experiencing an event in that secondary prevention population. But the CV risk factors also need to be controlled. So we're looking to rule out any inequities in the management of these comorbid risk factors. So hypertension, cholesterol, chronic kidney disease, whatever other comorbidities they had should be controlled equally on the side of placebo and the intervention. What should the standard CV endpoints look like? The standard CV endpoint for a cardiovascular outcome trial is something called MACE. It's a composite endpoint of actually 3 endpoints: cardiovascular death, MI, and stroke. Okay? And this is the standard that you see across this space and in the cardiovascular space. Sometimes you might see MACE plus the use of additional endpoints like hospitalization for heart failure, hospitalization for ACS, unstable angina, etc. And the use of a broader MACE, use of more endpoints, allows you to increase event rates and therefore may reduce the sample size needed to achieve the effect that a trial is trying to accomplish or trying to see. So given that this was an FDA mandate and manufacturers had to conduct these trials in order to safely provide the medicines in market, most could not follow those 45-year-old young patients over 10, 20 years, decades to see events. And so we see that, as you'll see, these trials are designed differently to look at different patient populations. So what happened since the FDA guidance in 2008? Manufacturers of newer type 2 medications and existing ones in the market designed and conducted large phase 3 clinical trials evaluating the cardiovascular risk of their investigational drugs. So if you look at this timeline, each trial is color-coded by their respective class and link up with the timeline shown. You see the first trials to read out are those in the DPP-4 inhibitor class, the light gray. So those are Saber-Timi, Examine, T2D, okay? And they've been on the market the longest. In general terms, this class has been shown to be CV safe, okay? So they don't incur additional CV risk compared to placebo, but also no additional CV benefit. We also see this with the first GLP-1 receptor agonist cardiovascular trial, ELIXA, in 2015. That's a short-acting GLP-1. It's taken once daily. This trial looked to include patients shortly after experiencing ACS, followed them in about 1 to 2 years, very short time frame, and so may not have had the time needed to see effects on reducing atherosclerosis. Okay, And then you see in pink trials in the SGLT2 inhibitor class, in light yellow or orange, the GLP-1 receptor agonist class. There's actually been a trial with insulin, CVOTs, TZDs, and alpha-glucosidase inhibitors. The focus of this talk will really be on the SGLT2 inhibitor and GLP-1 receptor agonist classes, because these are the classes where we first saw benefits on cardiovascular risk. So as I mentioned earlier, because the trials were not designed identically, manufacturers were given principles for how to conduct the trials. The patient populations differed between classes and within classes for developing cardiovascular risk. Here's a breakdown of patients with and without atherosclerotic cardiovascular disease in each of the trials by class. So the red portions of the pie chart represent patients with risk factors alone, blood pressure, cholesterol, etc. Although I will say as a caveat, even this is not consistently defined across trials or across classes. So where you see more red, there may be a trial that looked to really take in those 45-year-old patients with risk factors alone. In other trials, they may have had some evidence of disease on radiography. So the definitions differ across trials, and you'll see this as you read their baseline demographic papers for each of these individual trials. The blue parts of the chart, pie charts represent those with established cardiovascular disease. So those patients who have either experienced an event like MI or stroke or some kind of clinical manifestation of a vascular disease, or have significant evidence by angiography, ultrasound, MRI, etc. I do want to point out, while they largely enrich their population with these sicker patients, that bar on the bottom, in most patients, in the general type 2 diabetes population, only 20% have established cardiovascular disease. So you need to keep these considerations in mind as you look at the trials, their results, how the patients present, and what they're most likely to experience within a length of a trial. So what happened since many of these trials completed? By the end of 2015, we see the first positive results for the FDA-mandated cardiovascular trials, where in the SGLT2 inhibitor class, starting with empagliflozin in what was now considered landmark results in the EMPA-REG trial. The primary outcome was the composite MACE that I described earlier, consisting of three subcomponents: cardiovascular death, MI, and stroke. Okay, what I want to point out to you here, if you had seen, these are called Kaplan-Meier curves. If you've seen the Kaplan-Meier curves of the DPP-4 class and ELIXA, those lines would be right on top of each other. You would not be able to distinguish a separation. For the first time with these diabetes cardiovascular outcome trials, you see a separation of curves, and it's significant. The red line is represented by empagliflozin, the gray line by placebo, and you see that the patients on the SGLT2 inhibitor empagliflozin are experiencing less MACE events than placebo. How much? On average, the relative risk over time is 0.86. The confidence interval ends at 0.99, less than 1. This translates to a relative risk reduction of 14%. And it is statistically significant for superiority. So not only is it safe, like the DPP-4s and ELIXA, it's actually counted to be superior to placebo for reducing cardiovascular events. The other thing I want to point out here, because these profiles will look different between the classes, is how early the lines separate. Okay? You're seeing this as early as 3 months. Less than 6 months, we start to see a signal that there may be a benefit. As we looked further down into these results, what was driving the MACE? Okay, I mentioned that there were the components, CV death, MI, and stroke. Well, when they looked at those results together, the MI and stroke really were not contributing to the overall MACE results, but cardiovascular death was. And from what I hear, when these results were first presented at EASD a few years ago, this was received with a jaw-dropping applause 38% relative risk reduction in cardiovascular death. That's a hazard ratio of 0.62. Confidence interval ends well below 1, highly statistically significant. Again, the curves open up very early on, 3 months and as little as 6 weeks we've heard, for effects on cardiovascular death. And so more speculation begins. How are these SGLT2 inhibitors behaving? We know their mechanism of action to reduce glycemia, but how are they acting in their non-glycemic effects, in these off-target effects? We know that they have effects on blood pressure, natriuretic and glucoretic effects. There's speculation on the heart. And so further down, as the manufacturer, BI Lilly, looked into their results, we see that cardiovascular death effect is really driven by a reduction in hospitalization for heart failure. And again, the drivers seeming to be maybe by blood pressure and volume effects, but also those putative effects I mentioned, perhaps on electrical conduction and sodium-potassium exchange. Here again, the result is highly statistically significant, 35% relative risk reduction in hospitalization for heart failure, happening very quickly with this class. I'm harping on this a bit because I want you to understand and remember that while the SGLT2 inhibitor class did show a benefit on MACE, we're really seeing this signals further down, cardiovascular death, but particularly hospitalization for heart failure. And later I'll touch on CKD, or chronic kidney disease. And this is really what influenced the updates to the guidelines that we see today. So how did the GLP-1 class fare in comparison? Here we have LEADER. This is a study evaluating liraglutide, the GLP-1 receptor agonist, on their primary outcome, MACE. First GLP-1 cardiovascular outcome trial to show a benefit on MACE. You see a similar relative risk reduction, 13% below the confidence interval ending less than 1, and statistically significant for superiority versus placebo. Now remember the profile of the SGLT2 inhibitors. They happen very quickly, less than six months. With the GLP-1 receptor agonist, using this as an illustration for the class, you see that it doesn't open up as quickly. Really starts after 6 months, closer to 12 to 18 months. And so cardiologists and endocrinologists alike in both communities, practitioners in both communities start to speculate that this looks to be more like the atherosclerotic effects we see with the antihypertensives, the statins, platelet medications, and so forth. So not only do these classes have different mechanisms of actions for glycemic reduction, but also in their cardiovascular risk reduction. And so, as I said, we use these as illustrations. I won't be showing you the Kaplan-Meiers of each of the trials that have read out, but there is a similarity in the direction and magnitude overall. So a couple of meta-analyses were published to help synthesize the learnings from these trials within each class, and to also help dictate where their place in therapy should be for type 2 diabetes management. Across the top there, we have the first meta-analysis of the GLP-1 receptor agonist class. This is a meta-analysis that was published 2018 in Lancet Diabetes, and it focuses on treatments that are available in the U.S. and published. And I have to say that because I showed you pie charts for Harmony, which evaluated albiglutide. That, unfortunately, is no longer available in the U.S. On the market, and also Rewind, which evaluated dulaglutide or Trulicity. We don't yet have the full results published. We have top-line results. So this meta-analysis only includes published results of available GLP-1 receptor agonists. As we walk through this, and you start with Alexa, as I mentioned, CV safe. It's right on the line of unity. Doesn't show really an increased risk versus placebo, but no increased benefit. As we walk down to LEADER, walk through that already. We have a strong point estimate, less of the line of unity, favoring liraglutide. Confidence interval is there, and it's statistically significant versus placebo. SUSTAIN 6 evaluated semaglutide. Here you have a smaller point estimate with a wider confidence interval, but still left of the line of unity, favoring the class. This was a smaller trial that was really designed to show safety, but really showing the signal of how this class acts. And finally, Excel, strong point estimate, similar to LEADER, is the largest CVOT in the class. The confidence interval ends right at 1.00, and so it did not meet statistical significance for superiority. But as you look at the overall result for the class, that large diamond on the bottom, it is ending at 0.99, favoring the GLP-1 receptor agonist class for the primary outcome of MACE. Okay, so remember the illustration of liraglutide with that long developing atherosclerotic effect on MACE seems to present in this way for the class. As we look down at SGLT2s, a meta-analysis was also conducted, published in Lancet this year by Zelniker et al. This breaks it out differently, and it reflects the evidence that has evolved over time. Okay, it does break it out by those patient populations because we really see that many of these results, most of these results are being driven by the patients who have already experienced an event or already have evidence of disease versus those who have risk factors alone. Also want to point out you won't see EMPA-REG in that breakdown for risk factors alone because in that pie chart, as you may remember, it was almost 100% patients who had already had an event or had significant evidence of disease. DECLARE, I want to point out, had the ability from EMPA-REG to redesign their trial, looking at the evidence of how SGLT2 inhibitors behave and to elevate hospitalization for heart failure and cardiovascular death as a primary endpoint along with safety and MACE. Okay? And that reflects the signals that we were seeing earlier on with EMPA-REG. So what does it look like? As we walk down MACE with those patients who have already experienced an event or have disease, we see a general trend for all those confidence intervals being largely left of the line of unity. You see that diamond also being left of the line of unity, favoring the class for MACE. However, when you look at patients who only have risk factors, really don't have a disease, that effect really falls apart. We don't see that benefit. It's right on the line of unity. These patients, for these patients, the class is safe for an overall benefit on MACE. Okay, but as I discussed earlier, what was really driving the benefit on MACE? Cardiovascular death and further down, hospitalizations for heart failure. Okay, that was really the strongest signal for this class. And in this meta-analysis, you see, regardless of patient population, whether they had established disease or not, risk factors alone, there's a strong signal that this class provides a benefit for reducing hospitalizations for heart failure. One other endpoint that I could not just go into a lot of detail because of the scope of this talk is the renal composite. All right, now this is a secondary endpoint in many of the cardiovascular outcome trials, and we will have a webinar later in this year focusing on renal outcomes in type 2 diabetes patients. But whether it was improvement of albuminuria, development of end-stage renal disease, renal death, any endpoint that was included in the renal composite of these trials, again, we see strong effects from the SGLT2 inhibitor class, regardless of the patient population. Okay, and I want to emphasize this and the hospitalization of heart failure because you'll see that these two effects really impact their place in therapy in the guidelines. MACE, as you'll remember, is really in favor of the GLP-1 class for a more atherosclerotic, for its more atherosclerotic benefit. All right, so how are these findings integrated into the guidelines? Actually, we started to see this in the ADA draft guidelines, which they shared back in June of 2018. This evolved in a consensus statement with the EASD in the fall, and finally they published their standards of care last month, where they really tried to integrate the findings from the CVOTs into their position statement. . All right. And it is not my intention to walk through every bubble on this chart, but we can really be impressed that ADA managed to put it all on one slide. Do want to remind you that first-line therapy remains with metformin and a comprehensive lifestyle management. This is consistent with how the cardiovascular outcome trials were designed also, that there was rigorous, that patients came in on metformin at least and had comprehensive lifestyle management in the background. The focus, however, is on that established atherosclerotic cardiovascular disease patient or patients with chronic kidney disease, okay? So ADA is asking healthcare providers to assess risk on these points first before you decide on a class of drugs. If they do not have established cardiovascular disease or chronic kidney disease, then you can focus on more patient preferences and patient needs. If the patient needs to minimize or avoid hypoglycemia. If there's a patient who needs to have additional weight loss or avoid weight gain. And finally, in those patients for whom cost is a major issue, but I want to remind you that it is for patients who don't have pre-existing cardiovascular disease or chronic kidney disease. Cost should only be the driver if they don't have those other complications in their background. So as we drill down to that first arm of the algorithm, focusing on those patients where established cardiovascular disease or chronic kidney disease predominates, you drop down this treatment arm and remember atherosclerosis. An atherosclerotic effect was seen more so with the GLP-1 receptor agonist class, although the SGLT2 class did see that benefit with EMPA-REG and CANVAS. And so they recommend a GLP-1 receptor agonist with proven cardiovascular benefit or a SGLT2 inhibitor with cardiovascular benefit. Whenever these guidelines refer to cardiovascular benefit, they are deferring to label indications. So the prescribing information of the individual drugs that have indications for cardiovascular benefits, okay? So they can start with a GLP-1 or an SGLT2, but if A1C remains above target, then when you look to add additional classes, be guided by the evidence. Either switch to a class that you haven't used that has benefit, or choose a class that has demonstrated safety, the DPP-4 class. There are insulins also, insulin degludec and U100, that have also demonstrated safety. Okay. Last, you would consider basal insulin, TZDs, and SUs. All right. So these are the principles that are guiding class selection. ADA really doesn't have a preference left to right, but they do have a hierarchical recommendation once you choose a class. All right. And I'll show you that principle as we walk through. On the right side, if heart failure or chronic kidney disease predominates, they have a different set of recommendations, all right? And while you might not link heart failure and CKD together as they're really different systems in the body, what is guiding this is the evidence that we saw from the SGLT2 cardiovascular outcome trials. We saw those strong effects for reducing hospitalization for heart failure and for improving those renal composite endpoints. So preferentially, they recommend an SGLT2 inhibitor with evidence, okay? And we saw that regardless of patient population with the renal composite, but also to some extent with the hospitalization for heart failure. So start with an SGLT2 inhibitor. They say that you can also look at GLP-1 receptor agonists if the eGFR is adequate, okay? And then if A1C remains above target, think about this patient, right? They have heart failure or they have CKD. So in this patient, you would avoid a TZD first in the setting of heart failure. Then again, same principles. Choose class that has CV safety, DPP-4 inhibitors. And then basal insulin, SUs last, also something to avoid with heart failure. All right, so this covers that first arm of the algorithm when your patients have already had established cardiovascular disease, heart failure, or chronic kidney disease. How about those patients now shifting over to the rest of the algorithm who don't have disease but want to avoid hypoglycemia? Okay, so again, as I mentioned earlier, there is no preference left to right, but once you choose a class, you should follow the hierarchy that they recommend. So if you start with an SGLT2 inhibitor, next, consider adding a GLP-1 receptor agonist because it has evidence for cardiovascular benefit from the cardiovascular outcome trial. So they're still trying to provide that benefit early on to patients. If you start with a GLP-1 receptor agonist, then go to an SGLT2 inhibitor. Again, remember those prior patients. Those patients who only had risk factors alone, they still benefited in a reduction of hospitalization for heart failure and CKD. So we still want to introduce that benefit to patients even if they don't have established disease, and so forth with TZDs and DPP-4s. Now, as you look down, there is a hierarchical recommendation for any of these pathways that you want to avoid and use perhaps FUs and insulin, certain insulins, last when you're trying to avoid hypoglycemia, right? So they recommend using third-generation FUs and newer insulins with lower risk of hypoglycemia. So again, looking at your patient and what they're at most risk for developing complications for. All right, and then for those patients who need weight loss or need to minimize weight gain, you can start with a GLP-1 receptor agonist with good weight loss efficacy or an SGLT2 inhibitor. And then if A1C remains above target, switch to the other class. These are the classes that have good weight loss efficacy. We know that with the GLP-1s, SGLT2s also provide that through caloric loss through the urine. And then, again, looking at the evidence, consider those agents which have a low risk of weight gain or are weight neutral. Just as the DPP-4s are CV safe, they are also weight neutral. And then last, consider the addition of FUs and insulin, TZDs, which may cause weight gain. Finally, those patients with cost issues, and I really want to emphasize that these are patients who do not have existing cardiovascular disease or CKD. If there are patients for whom cost is a major issue, but they have disease, please work with your systems and the drug developers to get those to get those drugs with benefit for your patients so that they can also have access to affordable drugs with benefit. But in the case that they don't have that, the drugs that are available, FUs, TZDs, and insulin, that may be more affordable for them if these other complications for risk do not exist. The last arm, which I didn't show in the overall approach, just want to give you the update that ADA has provided a key addition to their consensus report in terms of their place of therapy for GLP-1s before insulin in most clinical situations. Again, reflecting the evidence that we're seeing from the cardiovascular outcome trials. If the patient's already on injectable therapies, they want to be able to provide that benefit if possible. Of course, if a patient comes in and their A1C is over 11% or 2% above goal, they recommend starting with insulin. But otherwise, the addition of a GLP-1 receptor agonist should be considered for those patients on injectable therapy. And so I'll pause right there and just ask you, Curtis, your thoughts. I know we rolled through a lot, starting with the FDA guidance, some key findings from the trials and the classes, and then the ADA, which really tried to integrate these findings. So just want to know your thoughts from the clinical side on these standards of care.
Well, these are a huge, huge step forward, and one of the things I think we would all agree on is, you know, the guidelines up till now have been extremely glucocentric, and you know, it's wonderful now that we've started to have this data start coming out since 2015 that ADA and ACE have started to incorporate in and actually emphasize non-glucocentric parts of the drugs. So I think that we need to understand that this new non-glucocentric view doesn't take away from the fact that we want glycemic control. What it's doing is it's helping you individualize therapy even further. So I think this is a huge step forward for ADA and for the general population treating type 2. This is really a new paradigm. They need to really start thinking of these drugs totally different than they used to.
Yeah, that's great. Thank you, Curtis. Appreciate that, and that's definitely what we see as we look at other updates to guidelines. So, of course, these were landmark findings, and they caught the attention of the endocrinology and diabetes community, but they were also noticed by the cardiology community. And so, because they see the patients, the type 2 patients who've had events or are at high risk for an experiencing event, ACC came together and published their expert consensus decision pathway on therapies for cardiovascular risk reduction in patients with type 2 and atherosclerotic cardiovascular disease. This was published at the end of last year. And given the findings that we discussed, they have also provided an algorithm, which I will show you on the next slide. We won't need to go into things in as much detail because we've really covered the evidence behind it. But briefly, ACC created a roundtable with experts across specialties, so family and internal medicine, endocrinology, of course, cardiology, and across the spectrum of providers, pharmacists, advanced care practitioners, nurses, and physicians. They did a really nice review. If you get a chance to read that consensus pathway statement, they did a really nice review of the SGLT2 class, the GLP-1 receptor agonist class, both the benefit risks of the drugs themselves. And I would remind you, we're not going into details of the clinical profiles of these classes. Please do look at their prescribing information if you need more information. But they went through that. They discussed the findings from the cardiovascular outcome trials and then came up with recommendations that they wanted to be practical for providers across the medical community. The key takeaways were this. They recognized what Curtis mentioned, a need to shift the paradigm from focusing only on glycemic control to something more comprehensive for reducing cardiovascular risk and preventing cardiovascular death, very important for cardiologists. They also recognize that emerging therapies have proven to reduce cardiovascular death, especially in patients with established cardiovascular disease or those at high risk, and that cardiovascular clinicians have a role in prescribing these drugs, not only clinicians in the diabetes space. Briefly, they recognized that at least 2 drugs demonstrated reduction in MACE in the SGLT2 class, also in cardiovascular death and heart failure. The GLP-1 receptor agonist, 1, significantly reduced cardiovascular events in MACE. So those were really the key takeaways of the consensus statement. And with that, they proposed a streamlined algorithm for the patient with type 2 diabetes and established clinical atherosclerotic cardiovascular disease. So as you go down this algorithm, it's not as comprehensive because really they want their practitioners to address things concurrently. On the left side is a bucket which really has many buckets underneath it. They want HCPs to use guideline-directed medical therapy to address antiplatelet, blood pressure, lipid issues, glucose lowering, of course, and lifestyle modification. So there would be algorithms under each of these. Apart from that, without definitively knowing how these classes of drugs work, they would like HCPs to consider the addition of an SGLT2 inhibitor or a GLP-1 receptor agonist with demonstrated CV outcome benefits, okay? And they're suggesting to CV specialists to initiate those conversations with patients at their next follow-up visit. And they also recognize that when patients are discharged from the hospital, they're also most likely to be most adherent. So that's another opportunity to discuss these classes of drugs. And once they have, on one hand, they've recommended broadly to continue these guideline-directed therapies. On the other hand, on the right side, they've recommended considering these 2 classes similar to ADA. And so with both classes of agents having non-glycemic benefits in systolic blood pressure, weight with a low risk of hypoglycemia, they do, in their statement, recommend for patients at high risk for heart failure or established heart failure to start with an SGLT2 inhibitor, okay, with demonstrated benefit. For those patients who are looking for substantial weight loss, maybe have some adherence issues, and are looking for an overall reduction in MACE, atherosclerotic benefit, think about a GLP-1 receptor agonist. Okay, and so these are how they have integrated findings from the cardiovascular outcome trials into their practice recommendations. Finally, we'll end with the last and most recently published guidelines from the ACE and ACE type 2 diabetes management algorithm. These guidelines I'll review, but really with a focus on anything that included updates from the cardiovascular outcome trials. It's really not to be a comprehensive review of the algorithm. It's really just focused on updates from the trials. Just as a disclaimer, I wanted to share that these slides are freely available on the ACE website for educational purposes. So I do encourage you to check these out along with their larger executive summary. My overall statement about this is that the principles remain the same. Much of this has not changed in terms of their recommended treatment goals and their treatment approach. It continues to be stratified by baseline A1C because they have previously tried to incorporate cardiovascular risk in their recommendation for what types of classes of drugs to choose. So while ADA and ACC have explicitly integrated that approach, integrated the results into their approach, it's more subtle, and that's what I really want to point out, where ACE has already incorporated it, and also in their recommendations, their hierarchical recommendations in their glycemic algorithm. So with this one, not a new slide, looking at those type 2 patients who are overweight or obese. As you know, obesity is a chronic progressive disease associated with an increase in morbidity and mortality. And so ACE recommends evidence-based treatment for these patients to address the complications of obesity. So rather than a BMI-centric approach, they want to look at that cardiometabolic disease and biochemical complications, a complication-centric model. So you'll see they've staged it a bit. You can look at your type 2 patients with a BMI of less than 25, BMI greater than 25 with no complications, and then BMI greater than 10 or 20, greater than 25 with complications. So here is a place where they're asking you to look at cardiometabolic risk. Next slide, pre-diabetes algorithm, not a new slide. Where they've addressed cardiovascular risk is in the beginning, okay? So these patients don't have type 2 diabetes yet, but they want you to look at those risk factors and aggressively treat those risk factors. They have a dyslipidemia route and a hypertension route, which I'll show you in the next slide. Again, addressing dyslipidemia and hypertension separately, but throughout this algorithm, constantly assessing for atherosclerotic cardiovascular disease and helping the practitioner to assess their risk level, high, very high, or extreme. So they, for example, list a high risk patients with diabetes with no major risk factors and age less than 40. Very high, patients with diabetes and some evidence of disease with risk factors, and extreme risk as patients with diabetes with established clinical cardiovascular disease. So ACE, again, has not put it in their glycemic recommendations, but they want it to be addressed while you are trying to manage their other cardiovascular risk factors. And finally, the glycemic control algorithm, okay? So taking the evidence into account, you'll see that, again, the treatment stratified by baseline A1C, that has not changed. However, they did extend the strength of recommendation. You see those bars, those green lines under SGLT2 and GLP-1 receptor agonist class, recommending to be used in patients with atherosclerotic cardiovascular disease or renal disease. They footnoted where they're trying to implement the evidence into their algorithm, okay? And if you read the 2019 executive summary, results from other trials are starting to be included. So results from DECLARE highlighting the reduction in the composite for hospitalization for heart failure and cardiovascular death, consistent with the class. ACE does not include results specific for patient population. So you don't see that breakdown as you did with ACC and ADA here. But they've updated their evidence through their executive summary and with additional notations around this algorithm. So you'll see results discussed from EXCEL, the trial evaluating once-weekly exenatide, SUSTAIN-6, looking at semaglutide, and preliminary results from REWIND, suggesting that other GLP-1 receptor agonists may also confer a benefit in addition to liraglutide. And the last slide from this algorithm, again, not new, but just pointing out where they've tried to implement evidence from the trial. You'll see if you look across cardiovascular disease, renal disease, and evidence from the trials, they've tried to show you where, how these profiles are, where the evidence is dictating these profiles. Green represents few adverse events or possible benefits. So for example, with renal, you can see a possible benefit in the SGLT2 class and for cardiovascular risk with SGLT2s and GLP-1 receptor agonists. So with that, I know we've run through a lot of information from all of these guidelines. I hope you'll remember that all of this started with the FDA guidance back in 2008, where they were really trying to rule out additional risks. But here we've seen evidence for benefit with certain classes of drugs. More is still to come in terms of studies that will read out. And the guidelines are now already implementing them into practice recommendations for your patients with type 2 diabetes, and especially those with established atherosclerotic cardiovascular disease. And with that, I will end. Thank you very much.
Great, thank you. So at this point, we'll move on to the question and answer portion of the webinar. So if you have a question that you'd like to ask our presenters today, you can type it into the Q&A box on your screen, and we'll answer as many as we can in the next 12 minutes or so. So the first question we have is for Curtis, and it says, would you recommend an SGLT2 inhibitor for someone with type 2 diabetes and heart failure with ejection factor of 15%?
Well, it's a really good question, and of course, I'm sure what the person is mostly concerned about is the fact that that's a pretty low ejection fraction. I don't know how it was measured, but and that can affect what the actual measured amount is. But no matter what, it's quite low. So less than 20%, we worry about so many different things, and obviously we do know that less than 20%. Now we're getting into the point where people are end stage, and we worry about having to get them a transplant or them just basically having pump failure. So of course, the first thing is we want to make sure they're on optimal therapy. If they can, beta blockers, aldosterone receptor blockers. We want to make sure that they have HRR. But on top of that, I mean, it's clear that at least from the data we have, and of course we don't have the large heart failure outcome trials in this class yet, but it's clear that people with higher BNP actually were the people getting the benefit of decreased heart failure hospitalizations. So it is something to consider, especially if you're seeing that this person is a frequent flyer into the emergency room for heart failure hospitalization, which of course most people are trying to minimize, especially in this population. So I would say, if possible, it would be a very appropriate addition to their therapy.
Wonderful, thank you. Susan, the next question we have is for you, and it says, why does the ADA EASD algorithm seem to focus on cardiovascular disease so early in clinical decision making?
Right. So as I walked through, I think there's two perspectives, right, for the cardiology community and for the endocrinology community. I think these results were findings that they just could not ignore. They will be used, these drugs will be used in any case for glycemic management, but in the cardiology community, they wanted to see that, basically that you're preventing an additional event, that you're preventing more disease, preventing death, whatever it is. And so if there is some benefit early on, they want to introduce that into the thinking of the healthcare providers. That's what I'm seeing from this. And also, like I showed you in a few of those meta-analyses, especially for the SGLT2 inhibitors, regardless of the patient population, whether they had disease or not, you saw a benefit for reducing hospitalization for heart failure and CKD. So the question is there of whether those patients should have these drugs early on, much like the question that was just asked of Curtis, even if they don't have, even before they have disease. So I think they just want to catch it early and help HCPs be thinking about it early on.
Also, if I mention one thing too, I want to remind the audience that the benefit was seen very early. So I want to remind them that within 3 to 6 months, that the benefit with the SGLT2s was seen for the hospitalization of heart failure. I mean, almost immediately. So I think that's an important follow-up to that if you have someone that you think is high risk for heart failure or has it, you put the drug on and immediately you see a reduction in hospitalizations, which is, each hospitalization for heart failure can be quite expensive. So.
That's true. That's right.
Great. Thank you both. Curtis, the next question is for you, and it says, the ACE algorithm seems more aggressive than the ADA-EASD algorithm when treating hyperglycemia. Is this a different focus, or does ACE not think that cardiovascular disease is as important?
Well, I think Dr. Thomas kind of addressed this a little bit. So if we kind of talk about that in two phases, one is the glycemic goal, which is slightly different, more aggressive, as if you wanted to put it that way, for ACE versus ADA at 6.5 for ACE versus 7% in general for ADA. But I do want to remind people that this has to be individualized. So if we just talked about the person who has a heart failure ejection fraction of 15%, I don't think anyone would be out there recommending less than 6.5%, especially with the mortality rate of 75% in 3 years for someone like that. So, we have to individualize this based on the person in front of us, comorbidities, how severe those comorbidities are, and go forward. The quick answer to it is that ACE chose to incorporate more evidence into their hyperglycemia goal. They chose observational data from large clinical trials, whereas ADA tended to go with what was the outcome A1C from those trials. And so based on that, that's why ADA ended up at less than 7, ACE ended up at less than 6.5. And then the second part of it is cardiovascular, which Dr. Thomas, I think, really clearly told you is that it's in there for ACE. So if you look at the ACE guidelines, in the summary, they clearly say cardiovascular comorbidity is a very important outcome. But instead of like ADA putting it separate on their algorithm, they just incorporated it into their second and third line therapy. And if you look, that's GLP-1s and SGLT2s. And they also, if you read the document, differentiate based on the underlying problem, recommending both for CKD, but also understanding if heart failure, you should go towards an SGLT2. So I think that they incorporate it all in there, but it's not so in your face like ADA, so some people think, well, maybe they didn't emphasize it, but it absolutely is in there.
Wonderful, thank you. Another question for you, if a patient is on a weight loss drug, should they consider stopping it if they start a GLP-1 or SGLT2?
It's a good question. I'll tell you, in our practice, it's not usual that we would be stopping the other medications unless there's some reason to do so. So I'll give you a very obvious one. if you're going to choose a different GLP-1, but you're going to be starting something like Saxenda, which is also a GLP-1, obviously we wouldn't put two GLP-1s on top of each other. The other thing to think about is, whether the mechanisms are complementary or not. So if the mechanisms are complementary, perhaps you would do it. And we tend not to stop them because I know that when you stop one of the drugs that's helping with weight, you tend to get a backslide in your patient with their weight. And of course, one of the things that ADA and ACE both recommend is trying to get our patients to lose weight. So in general, this backslide is something we don't want. So we would try to use those in combination, even though it's not recommended by a lot of guidelines out there right now, if possible. The other thing I just recommend is the fact to think about these drugs, even if you're using them for type 2 diabetes, glycemic control. One of the things that we're finding working very well these days is SGLT2s in combination with GLP-1 receptor agonists. And that's because GLP-1s decrease your appetite, SGLT2s make you pee out sugar, calories, but SGLT2 is a mechanism how they stop making you lose weight is that they make you slightly more hungry, which the GLP-1 blocks. So one of the things that we're finding is those combinations work very well to help people lose even more weight. So, and of course, last but not least, it's right in the guidelines. If your BMI is more than 35 with comorbidities, the most effective way of doing this is actually bariatric surgery if your patient qualifies and is interested, et cetera, et cetera. So it's a good question.
Wonderful, thank you. The next question, I think either of you can take this, but it says, will all these guidelines be combined into a single guideline that everyone follows, similar to the cancer treatment guidelines?
I have not
Susan,
heard
you want
that.
to start? Yeah.
Yeah, I was just going to say I have not heard that it would be combined. I mean, all of these are different perspectives, right? And so I think the most important thing is that these guidelines are reflecting the evidence and they're evidence-based, and that's what's most important right now. I'm not aware that they're going to be combined. How about you, Curtis?
No, I'm not aware that all the organizations will have a global algorithm anytime soon.
All right, thank you. And it looks like we have just one more question. Curtis, this one is for you. It says, there's a definite pill burden in patients when you consider that many are taking a statin, a hypertensive, a few diabetes medications, and often other medications. These guidelines are becoming more comprehensive, but do not help us address keeping our patients on their medications. Can you offer your perspective?
Well, it's a great question, and one of the things is I just want to emphasize that it's difficult to tell you a broad stroke way of getting this done. It really comes down to I call it 3 key points. One is kind of identifying the people who are having problems and then giving them education, and then individualization for the problem that they're having. And I say identification because I have patients who are on a lot of different drugs for type 2, and they're doing fine, and it comes down to identifying the ones that are having a hard time, and then the next thing is really about, once you've identified, educating about and figuring out why they're having a hard time. Is it something comorbidity-wise? Is it something that they're having a problem with cost? Is it something that it's just definitely just pill burden? One of the things that we're trying to do now is really address comorbidities, and that means things such as combination drugs, things that affect more than that, and the guidelines are clear with that. Drugs that help lower blood pressure, SGLT2s, drugs that help lower weight, SGLT2s, GLP-1s, things that could potentially decrease blood pressure medicines needed, maybe triglyceride-lowering medications. And then this double duty is really what we're trying to do. Also, and then educating them on other things that they could do. So one of the, of course, speaking from ourselves is, pharmacists are vastly underutilized. Go to your pharmacist, talk about medication therapy management, see if they can sit down and see if there's anything they can help you de-prescribe, things that maybe you're not needing as much. can decrease the pill burden. And then there's the overarching ones that most people are aware of, but we sometimes have to be reminded of, such as using combination pills. There's almost every pill in combination with metformin now, especially if you're on a stable, that would decrease pill burden. Recommending the simplest regimen, that could be a once-weekly GLP-1 instead of a once-daily for some patients to improve their adherence. And then just all I say overall is individualization of the intervention. What I've found in 20 years of doing this is that what intervention you did for the last patient to help them with pill burden is not going to work for the next patient. So you really have to individualize what works for them and just find a solution. Pill bottles, pill reminders, pill organizers, whatever works, individualize it to them to get to that root cause of the problem and then move forward. Thanks.
Great. Well, we'd like to thank Dr. Susan Thomas and Dr. Curtis Triplett for being here today and presenting these important updates. And we thank you all for attending today's webinar. This webinar was recorded and will be posted on our website, diabeteseducator.org, under the Education dropdown. It'll be available for only 60 days, so make sure you go in and check it out. Be sure to save these dates for the remaining webinars in this educational series. Thank you all. This concludes today's presentation.